topic of today's video is elbow joint dislocation and the terrible triad of the elbow. First, come to the anatomy of the elbow joint. Elbow joint consists of two joints, the humero-ulnar joint and the humero-radial joint. Humero-ulnar joint is basically between the trochlear notch of the ulna and the trochlea of the humerus, and the humero-radial joint is between the head of the radius and the capitulum of the humerus. Elbow joint has a capsule which is enclosing the joint. Joint capsule is thickened medially and the laterally to form a collateral ligaments. It consists of three bursas: intratendinous olecranon bursa located within the tendon of the tricep brachii, subtendinous olecranon bursa which is located between the olecranon process and the tendon of the tricep brachii, and the subcutaneous olecranon bursa which is located between the olecranon and the overlying connective tissue. Now come to the ligaments of the elbow joint. It consists of the three ligaments: the annular ligament which holds the radius and the ulna together. Ulnar collateral ligament, it extends from the medial epicondyle and attaches to the coronoid process and olecranon of ulna. It has three parts: the interior, posterior and the inferior band. The radial collateral ligament, it extends from the lateral epicondyle and blending with the annular ligament of the radius. The pictures is also showing the ligaments. The green one is the joint capsule, the yellowish one is the radial collateral ligament, the bluish one is the annular ligament, and the reddish one is the ulnar collateral ligament. Now come to the blood supply of the elbow joint. The proximal to the elbow joint, the ulnar collateral artery, radial collateral artery and the medial collateral artery, and distal to the elbow joint, the radial recurrent artery and the ulnar recurrent artery. Proximal elbow joint, the brachial artery give off the two branches, the superior and inferior ulnar collateral artery profunda. Brachial artery give off the radial collateral and the middle collateral artery, and distal to the elbow joint, the radial artery give off the radial recurrent artery and the ulnar artery give off the interior and the posterior ulnar recurrent arteries. Now come to the movements of the elbow joint. The flexion is produced by the bicep brachia and the brachialis which is supplied by the musculocutaneous nerve, and the brachioradialis which is supplied by the radial nerve, and the extension is produced by the tricep brachia which is supplied by the radial nerve. Now come to the stabilizers of the elbow joint, the static stabilizers and the dynamic stabilizers. Primary static stabilizers include the ulnohumeral joint, the interior bundle of the MCL and the LCL complex, and the secondary static stabilizers include the radiocapitular joint, the joint capsule which is the origin of the common flexor and the extensor tendon. The dynamic stabilizer include the muscle that crosses the elbow joint which supplies the compressive forces. It includes the anconeus brachialis and the tricep muscle. Now come to the mechanism of the dislocation of the elbow joint. Elbow dislocation is commonly caused by the traumatic fall on the outstretched hand, resulting in hyperextension injury, axial compression, the elbow flexion, valgus stress, and the forearm supination lead to the rotational displacement of the ulna on the distal humerus. Elbow dislocation is classified into two categories: the simplest one and the complex one. The simple, in which there is elbow dislocation with no associated fracture, and the complex, the elbow dislocation with associated fractures. It includes the terrible triad injury, in which there is elbow dislocation associated with the lateral ulnar collateral ligament tear, the radial head fracture, and the coronoid tip fracture. Various posterior medial rotatory instability, elbow injury associated with the LCL tear and the coronoid fracture. So here is a radiograph showing the terrible triad, in which there is a fractured radial head, dislocated elbow and the fractured coronoid process. So what is the clinical presentation of the elbow joint dislocation? Instability, popping sensation on immediate injury, the pain, weakness, reduced range of motion, swelling. The olecranon may be prominent, creating a divot over the distal tricep, joint line tenderness on the palpation. Elbow is commonly held in the mid flexion, whereas the patient with the interior dislocation tend to adopt a position of the forearm supination with the extension at the elbow joint. As we have already discussed, what is the terrible triad of the elbow? It is characterized by the presence of the elbow dislocation, often associated with the posterior lateral dislocation or the LCL injury, radial head or the neck fracture or the coronoid fracture. We have already discussed the mechanism of injury previously. The common presentation is pain, clicking or locking with the elbow in extension. The physical examination reveals the possible varus or the valgus instability patterns. So here's the radiograph is showing the interior dislocation of the elbow with the radial head fracture and the coronoid process fracture. Now come to the Ordriscoll classification system of the coronoid process fracture. In the type 1, there is a transverse coronoid trip fracture which affect one third of the process. And the type 2, there is injuries of the intermedial facet. It has a further two types, subtype 1 involvement of only interior medial portion and the subtype 2 involvement of the interior medial portion and the tip. Subtype 3 involvement of the interior medial tip portion and the greater than 50% of the tubercle. And in the type 3, they involve the coronoid process base with a disruption of more than 50% of the coronoid body. Now come to the management of the elbow joint dislocation. The non-operative management include the reduction of the elbow joint dislocation, immobilization in the 90 degree of the flexion in the full supination for 7 to 10 days. What are the indications of the non-operative management? The elbow is sufficiently stable to permit the early range of motion. Coronoid fracture is small, that is a type 1. The radial head fracture doesn't meet the surgical indication. Humero-ulnar and the radiocapitular joint have been anatomically reduced. Progressive range of motion is routinely instituted following 1 week of immobilization, with the active motion initiated in the resting splint at 90 degrees of the pronation, ensuring the avoidance of the terminal extension, with a static progressive extension splitting followed by the strengthening protocol beginning after the 6 weeks. What are the indications for the operative intervention? Unstable radial head fracture, type 3 coronoid fracture, associated elbow dislocation. And it includes the open reduction internal fixation versus radial head arthroplasty, LCS reconstruction, coronoid RF with the possible MCL reconstruction. And what are the complications? Complications include the instability, more common following the type 1 or the type 2 coronoid fractures, failure of the internal fixation, post traumatic stiffness, and the post traumatic arthritis.